Hello. It's good. All right. The clicker is being weird, so I may have to switch this manually. We'll see. Okay. Perfect. Thanks, everybody. Good morning. I'm Dr. Shadia Rapich. I'm a board-certified small animal surgeon, and this will be GDV. A couple of points to make. The proceedings for this talk are very, very detailed. They're really like academic. And so that's meant to be sort of a reference point. You can use that or not use it at your desire. I would like this talk to be a lot more practical, clinical. You can actually use the stuff we're going to talk about today. That's the idea here. So if you have any questions or anything, feel free to shout them out anytime. Or if you want to wait till the end, you can. It's up to you. But I hope you'll find some points here useful for you. So a little bit about me, if you don't know. I graduated from Kenneling University in 2006. I did a one-year general internship at Angel in Boston. After that, I did 2 surgery internships and a 3-year surgery residency at Long Island Veterinary Specialist. From there, I decided to leave the East Coast and moved to Las Vegas, where I worked in a specialty hospital. That was followed by managing 3 facilities in Silicon Valley, where I was on call 24/7 as a surgeon for all 3 locations. After that, part owner of a hospital in LA, and then I moved back to Las Vegas, where I currently own and manage Vet Triage. This is our outline for today. We'll talk about general prevalence for GDV, risk factors, etiology, pathophys behind it, the clinical signs, diagnostics, a little bit about stabilization, not too much. It's, of course, a whole talk on itself. And then, of course, the big part is going to be the surgical aspect to it, complications, mortality, outcome, some key points. And some of the topics here will be very rudimentary. Some will be, hopefully, things you haven't heard of before. So it should be a good mix. So GDV, the prevalence of GDV in dogs, 2.4 to 7.6 for every 1,000 dogs admitted to the hospital. So it's a very common condition. Anybody here who's worked ER, especially ER or GP, you've probably seen this in your career. And if you haven't, you probably will if you're dealing with small animals. Most of the affected dogs are males. They're middle to older age dogs. They're on the larger side, of course. And you have your standard deep-chested, large dog breeds, German Shepherds, Great Danes, standard poodles. That's your classic. I've had small breed dogs come with GDV, and we'll talk about this a little bit, but I'm not sure it's the same causality for the small breed dogs that is the large. But certainly if you have a small breed dog with symptoms that seem to mimic GDV, there's chances are it's probably something else. But regardless, it can happen in small dogs. It can happen also, I think there's one report of a cat that it occurred in, but the majority, the classic signalment is going to be a large breed dog. There are a ton of risk factors. In fact, the proceedings has an entire paragraph of all the risk factors that have been identified in the medical literature. The problem that I have with some of these risk factors is that the causality of it, if most dogs are affected in the summertime, let's say, but what does it have to do with GDVs in general? Like, can you connect that, or is that just happenstance? And so I tried picking kind of the bigger risk factors that I have seen as a surgeon that I think do play a role with this disease. So we do see in the older dogs, they are a larger breed. I do see that the dogs that eat a lower number of meals per day are more predisposed. I presume that's because if they're eating 1 meal a day, let's say, they're wolfing down their food, and part of this issue, of course, is a gastric motility problem. Temperament, the more anxious, high-strung dogs tend to be more affected with this, as opposed to the happy-go-lucky dogs. There's something to that, I believe, because a lot of the breeds that get affected by this, like Weimaraners, Vizslas, these tend to be a lot more high-strung animals. Family history of GDV, a history of splenic torsion, which by itself is, I think I've maybe cut 3 of these in almost 18 years, so to me they're not that common. A history of splenectomy, this is of course very common, so that has an incidence of 3 to 8%, giving them a 5.3 times risk of developing a GDV. Having a gastric foreign body has a 5 times risk, and if they're intact. So this is, part of the argument here is if you're chasing a gastric foreign body in a dog in surgery, should you pexy them at the same time? We'll talk more about when do you recommend a prophylactic gastropexy outside of the typical spay-neuter scenario. If you're in there for a pyometra or a hemoabdomen, do you pexy them at the same time? And so these are questions you've got to contend with and talk to the pet owners about pros and cons of adding this type of procedure, an elective procedure for an emergency surgery you're currently in. So I don't know the answer to it, but it's something to ponder. Same thing with splenectomies. If you're removing a ruptured splenic mass in the middle of the night in a dog that's not pexied, and it's your classic large breed, deep-chested dog, do you pexy them at the same time, balancing the fact that this dog is probably hemodynamically unstable from the hemoabdomen, you're trying to get them off the table quick, do you add another 15-20 minutes for a pexy or not? Regarding etiology, the real answer is, nobody knows what causes GDV, but we do see a combination of bloat and volvulus by definition. That's what a GDV is. And so it's a chicken and the egg scenario. What happened first? What caused the other? Are they both happening simultaneously? There are dogs that I believe I've seen that began with a bloat, and then because of the weight of the stomach, the pendulous nature of a distended stomach, it torses just by sheer anatomical variation, activity of the dog, size of the dog, there's more room in there, and then they have a volvulus, or dogs that start off with a volvulus, and then because of the volvulus, then gas and fluid build up and they get a bloat. We don't really know. Most cases are acute or peracute, really, but I have seen what I call chronic bloaters. I mean, some of you have probably seen those dogs that have a GDV, but they're walking in your office. No problem, just a big belly, and that's it. And I've had dogs that have had, if you investigate the history further, they have symptoms of GDV throughout their life, come and goes. And then at some point when I'm seeing them, it's no longer going, it's a GDV and they're stuck in that way. But chronic bloaters I do think exist. I've also had dogs that literally in surgery, as I'm trying to derotate the stomach is actively trying to have a volvulus again in my hands in real time. And so these dogs, to me, speak to like a peristaltic issue. They have like a hyperkinetic GI tract or something like that with these dogs. So it's not as simple as just a straightforward GDV, acute onset. I've seen ones that are a bit more on the nebulous side. And then the big question is the primary condition? Is it truly idiopathic? So I've had dogs, and I mentioned earlier about the smaller breed dogs. I've had dogs that come in for laryngeal paralysis that also have a GDV, or they have a liver mass and they have a GDV, they have a lung mass and a GDV. And so the question is, can I make the case that those primary diseases, let's say a lung mass, for example, did that lead to a GDV? Well, if it's altering respiratory function and they're gasping in more air and the stomach continues to get distended with air, I can make the case that that's more prone to volvulus. I can't prove any of that, but if I find a primary condition in a dog with a GDV, you're going to have to contend with both, obviously. You're going to treat the whole patient, but I'm curious as to whether or not it truly is idiopathic. And so the point of this is, how many of these dogs do we actually do a full workup on? It's the middle of the night, they come with the GDV, you diagnose it, you have your blood work, maybe you're doing the 3-view chest rads, everything looks good, you're in the OR. Are you really looking at, well, do they have a laryngeal mass? Is there an anal sac tumor? Are you really investigating that thoroughly? Or are we saying, yeah, GDV, straightforward, let's cut them? I don't have the answer. It's just a curiosity to me that we still think that this condition may be idiopathic, but I do think that if we investigate further in these dogs, a lot of them probably have a primary condition and you can make the case, predispose them to GDV. A lot of us use lactate concentrations to determine prognosis in these dogs. So how stable they are, what are the chances they have gastric compromise, gastric necrosis. It ties into lactate concentration, what are the chances they're going to survive after surgery. So if you have lactate in your facility, maybe add that on. The value of over 6 millimoles per liter gives you this sensitivity and specificity. So you can use that as a prognosticator. And then the average rotation in these dogs is 180 to 270. And this is, of course, what you're going to see in surgery when you open them up. You're going to have this a large distended stomach with omentum covering it, and it's classic GDV. And you may or may not have a hemoabdomen in there too. If the spleen's involved, the rupture of the gastric vessels. So what happens with these dogs with GDV? Well, it starts off initially with hypertension because of the poor vascular flow. Resistance goes up. It then affects the caudal vena cava just by sheer anatomy. The intestines then become affected as you lose blood flow to the GI tract. So bacteremia is 40% in these dogs. And this is an important point to make for any animal that you're treating for like vomiting, diarrhea, you know, where obviously we're very conscientious these days of the overuse of antibiotics. And if you can make the case that there's a potential compromise to the GI tract, that makes bacteria more prone to leave the GI and enter the bloodstream. So if you have a dog where you're worried about it, like an HGE dog, for example, is a great example of this, then having them on antibiotics, even in the absence of having a fever or a high white blood cell count, whatever, may not be a bad move. So I'm not advocating for the overuse of antibiotics, obviously, but you can make the case if there's ever GI compromise, whether it's GDV or something else, feel free to consider antibiotics prophylactically because of bacterial translocation across the intestinal wall. Then the portal vein becomes affected, compromised, which then, of course, hits the liver. You further progress with the risk of bacteremia. The pancreas can be involved, again, also because of blood flow and because of anatomy. So pancreatitis can be seen in these dogs as well as a secondary sequela to the GDV. The stomach, vascular compromise of the stomach, 10 to 30%. So this seems high to me. I don't see too many stomachs that are compromised, but again, as a surgeon, I tend to see these cases right away, and so it may be, my population might be skewed. The spleen can be involved, either repairably or irreparably, depending on what you find in surgery. It sort of depends. And then coronary flow, so the heart then gets affected. With a lot of these dogs having arrhythmias, usually ventricular, and that I do see very commonly, either pre-op, intra-op, post-op. It's very common. Everybody knows this, the clinical signs, so acute or peracute, non-productive retching, drooling, vomiting in these dogs with progressively distended abdomens, and then rapidly going into shock. And so this is the classic presentation of these dogs. This is what you're looking at when you're trying to prep them for surgery. Stabilization, everybody's going to have their own methods of tackling these dogs regarding stabilizing them for surgery, and it goes kind of beyond this talk, but I can answer any questions you like. The main goal here is getting large bore catheters in them and fluids to try and help with all that hemodynamic shock they're dealing with. And then while you're doing this, you're trying to provide gastric decompression. So trocaring the dogs, it is published and it does seem to be beneficial. I am not really a fan of it. My goal is to get them in the OR as fast as possible. So typically what I'm doing is they're induced as they're being clipped, the OR is getting ready, and then once the dog is clipped, prepped, ready to go, we're in the OR, and then my technician is passing a tube while the dog's in dorsal recumbency as I'm trying to actively derotate the stomach. And the reason for that is because I don't want to keep wasting time preoperatively with trying to decompress the stomach. I have to go in there anyway, and there's not that much time that passes between induction and getting him in the OR, and I have the abdomen open. Plus, if you've ever tried to derotate a GDV and you're having difficulty, some of that can be helped with the technician passing it over a gastric tube as it's starting to hit the distal esophageal sphincter. It actually provides some counter resistance for you, and it'll actually help you derotate the stomach as well. And so they can kind of pass the tube while you're decompressing, you're derotating the stomach at the same time. And then you get that release of gas and fluid, and the stomach tube goes through, and you've got a deflated stomach. So I tend to favor more of that approach, but again, as a surgeon, I have all the help that I need usually, and so I can move quickly and have things happening simultaneously. If you don't, then most folks, what they'll do is either trocar, which again, I'm skeptical of. It's just a small needle versus a large dog, but it's been shown in the literature that it is effective. Or put them in sternal recumbency and try to pass an orogastric tube before you go into the OR. And then if you do successfully pass the orogastric tube, then you've got more time to get the dog into the operating room to cut them, because theoretically you've released the pressure from the stomach. However you want to do it is fine. It depends on what staffing you have and how your processes are in the hospital. So this is my old technician, Alex, from New York, and this is us. We have the dog on the table here, the tube, and he's pumping water into the gastric tube, and then trying to help break up the kibble that's in there. This picture shows if you have got a dog who's really unstable and they're so unstable you're worried about inducing them. At the moment they have a GDV. If they're amenable to this, you can put a medical tape in their mouth, have somebody hold it, and then pass the gastric tube through the center there while the dog's still awake, and then hopefully they're awake enough to swallow, and then they can swallow the tube to try and decompress them. These are for really unstable dogs that you don't require any anesthesia because they're so obtunded from the shock of it. Otherwise, it's typically what most people are doing, either in lateral or sternal recumbency. They're trying to pass the gastric tube and decompress them in preparation for surgery.
Can we dim the lights a bit?
Oh, sure. If I can figure it out.
Maybe the other side. Maybe the other side.
The other side. Yeah. Any questions so far about what we talked about?
Yeah, quick question.
Yes.
Do you have any suggestions for if you're having difficulty passing the orogastric tube, but you're just not getting anywhere?
Yeah. Get into the OR. So.
But that is a thing. Like if you're
Yeah.
trying to pass the tube, and you just can't get into the stomach.
Yes. So if you can't get into the stomach, is this working? Oh, it's going. Yeah. Okay. So if you can't get into the stomach by passing it, then get into the OR faster, and then you'll have more control over derotating the stomach then. And if you're able to manually derotate the stomach in the OR, problem solved. I still pass the tube because you want to get all that crap out of the stomach. But once you've derotated in surgery, then of course, presumably the distal esophageal sphincter is now patent and you can pass the tube easier. Yeah. But yeah, part of the concern that we have too, if you're trying to force a tube in there is, well, are you at risk of perfing the stomach if you do that? And my answer is, in a healthy stomach, probably not. If you have a stomach that's got compromised already and you happen to hit the portion of the stomach that is currently compromised, then sure, you could go through the stomach, but at the same time, if you do, so what? You have to go in surgically anyway and fix this dog, and you're probably going to resect that portion of the stomach anyway, but so badly compromised that you were able to just pass a tube through the defect, through the stomach wall, it wasn't going to come back. So I don't really have the thought of like, oh, don't push too hard because you might burst through the stomach wall. If you did do that, which is very difficult to do, the stomach was probably so badly compromised, fine, it happened. You just have to go in surgically anyway and repair the dog. So I'm not too worried about putting too much pressure in there. But anyway, the real goal is getting the OR, and then you can try to pass the tube easier that way. So then in surgery, this is an example of a focal area of the stomach that's been compromised because of the poor vascular perfusion, and so the judgment call here is: do you leave this alone or do you resect it? We do know that partial gastrectomies do worsen the prognosis. These dogs are usually coming in more compromised, and if you have to resect the stomach, the prognosis is worse for these pets. And besides the fact that it adds to surgical time, and if you can prevent doing it, you'd like to. If we knew that in 3 days this is going to come back to normal color and texture, then of course we'd leave it, but we don't know. And at the time of surgery, you've got to make a decision. So it's based on experience level as far as color, texture, can you feel blood flow in here, and then sort of decide what you want to do. I've had clinicians, I have not done this myself, where they'll leave this, they'll repair it, they'll pexy the dog, and then in 2 or 3 days they'll re-explore them again and see what the stomach looks like. And that way you had time to stabilize the dog further, they're pexied already. So I don't have a good answer just yet, other than do your best judgment call while you're in there. You also may talk to the owner about this beforehand. When you're speaking to pet owners about GDV, you want to talk about arrhythmias, the need for splenectomy, gastrectomy. How much do they want to do in this 8-year-old Great Dane, with arthritis and degenerative myelopathy and whatever else got going on? The owners might say, well, okay, we'll just don't do anything heroic. If the stomach has to be resected, I don't want to do it. Or if there's a splenectomy involved or something, maybe I don't want to do it. Whatever that pet owner has as far as qualms about it, but it's something to talk about beforehand. Do I have permission to do whatever I think is best for this dog when I'm in there? That's essentially what you're asking their client. Have them give you the blessing to do that. GDV and surgery, this is the spleen. So the spleen gets wrapped up because of anatomical reasons and vascular reasons. It gets wrapped up in this mess. And the question is, if you see a spleen that's large, engorged, do you remove it or not? Obviously, if you have a splenic rupture, you're going to remove the spleen, so splenectomy. If the spleen is engorged, which is expected in like all of these dogs, is it still viable? That's when you go based on the blood flow to the spleen. You palpate the vasculature through the mesentery and see if there's blood flow. Can you feel clots in there? Can you not? Can you feel blood flow pulsing? Can you not? And then go from there. The risk with leaving a spleen that's been compromised is that splenitis, either sterile or infectious splenitis, is the concern. So splenic abscess, for example, which again I haven't seen ever, but I also tend to be more aggressive and I remove the spleen if I'm questioning the viability of the spleen. Dogs can do fine without a spleen, and so it's not as a big of a detriment as it is with people who don't have spleens. So if you're not sure, again, it's a conversation before surgery with the pet owner. You know, do I have permission to remove the spleen? Do I feel it's questionable or clearly not viable? Yes or no? Can I do that? And then if you do leave it in there, but you're questionable about it, just keep that in the back of your mind. If the dog is just not doing great after surgery, it's been a couple of days, and you're seeing all these, work the dog up, and let's see, maybe the spleen does have to be removed. So it's a judgment call. The ones that I've seen, usually to me at least, are fairly obvious. Like the spleen is ruptured and you can't salvage it, or there's a big thrombosis in the splenic veins. Yes?
Is it helpful pre-op to put your ultrasound probe on there and look for viable blood flow to help you in that process?
The question is, would abdominal ultrasound be helpful in trying to figuring this out? Yes, except, number one, most of the time, if you have a GDV in the middle of the night, what have you, getting an ultrasound, or someone who's comfortable with ultrasound is difficult as far as just skill set and manpower. But secondly, even more importantly, the large distended stomach, I'm not sure you'll see much with a stomach that huge. Yeah, it's gonna end up, because not only is the stomach massive, full of gas and fluid, it's also displacing all the intestines caudally as well. And a lot of these dogs have diffuse ileus too. All that gas, I don't know if ultrasound waves would. Yeah. But ideally, yes, because if you could ultrasound these dogs preoperatively, then you can use Doppler and see the blood flow to the spleen. Is it compromised? Is there a torsion? Is there a hemoabdomen in there? Absolutely. Yeah. So the gastropexy, the notes go into all different types of gastropexy that you can consider, and they all work well, So here's one where you create a muscle flap and you wrap it around the musculature of the abdomen and you tack it back down to the stomach, so you create this loop effect. Here's one where they're isolating the rib and then placing the same sort of flap through the rib there. Here's another flap idea, I don't know, but most of us are doing the incisional gastropexy, so I'll just show you that one. Because the incisional one, here it is. So the incisional gastropexy is typically what we're doing here. You're going to, this is laparoscopic, of course, so this is obviously not a GDV, this is prophylactically, but you're making an incision along the stomach wall here at an area that makes sense for the anatomy of the dog. That you want to be able to have the stomach contact the abdominal wall, and every dog's anatomy is a bit different, so you don't want to necessarily make your incision over the pylorus, the pyloric outflow tract, but you want to be somewhere around the antrum of the stomach, and you're making an incision in the stomach itself, superficial, just the first layer, and you're making another superficial incision that's going to match up with the stomach along the abdominal wall, and then the idea is when you have these two in contact with each other, you're going to suture them. So the incision here, if you can imagine, and let's say you're standing over this dog, right? So down here is going to be dorsal. It's ideal, I think, to have your simple continuous pattern along the dorsal incision first, because it's going to be deep to you. Once you attach the stomach wall to the abdominal wall with a dorsal incision, then the ventral incision, the one that's closer to you, can then be sutured. Because you can imagine how annoying it'll be if you do it reverse. If you're suturing the stomach to the abdominal wall, starting off with the incision that's closer to you, great, now those two things are together, but now you've got to figure out how to make that second closure dorsally. So start with the deeper of the two incisions, or sides of the incision, and then go to the ventral. And you should end up with a nice gastropexia like this. That's what you're looking to achieve there. So here it is in an actual abdominal exploratory. This is beautifully done. You have a simple continuous pattern. So this is what I was referring to before. This would be, I would consider this the ventral portion of the incision. That's the one that's towards you. You did the same thing here, but dorsally, deep to this, right? Attaching the stomach wall to the abdominal wall. So you have two simple continuous layers for the gastropexy in order to achieve successful adhesion. The adhesion length varies. I mean, for me, I'm not measuring it. It's just I'm trying to create as big of an adhesion as I can. But this is what they typically quote, and you're looking at being somewhere oral to the pylorus. But again, 6 centimeters depends on the size of the dog, of course. So you just have to use common sense when you're in there. You don't want to be right over the pyloric outflow. And mean surgical time is about an hour. I would say when you do enough of these, you're looking at 30 minutes or less for these surgeries. So a drawing of what I'm talking about here. So this is an incision in the stomach wall, just superficial layer, right? You're not going deep. And the stomach, the two layers of the stomach, they really separate nicely. So this is not hard to do. I've never accidentally entered the stomach. You have to literally try to do that in order to get into the stomach. So you're making an incision fairly superficially with the scalpel. Grab Metzen bombs. You can tease away that layer. So you can separate the two layers of the stomach. You can use Metzen bombs to do that. And then you're making another incision, same length, on the opposing abdominal wall, right? You're going to make sure these two things can touch, nice and easy, not without any tension. And then this is what I would consider the dorsal portion of the incision when it's deeper to you. Simple continuous pattern, attaching stomach to abdominal wall, and then that's followed by the ventral incision. And then you should end up with this. How many folks here have done gastropexies? Yeah, a lot of people. Yeah. What's great about doing it in like your spay, for example, besides the fact that it's medically appropriate to do so in the dog with that signalment, is that you get to practice it in a non-emergency situation, and so it's a straightforward surgery. You just want to make sure you have technique down before you're jumping into a hemoabdomen with hypotension and arrhythmias. So you like to be more controlled setting if you're going to try and dive into these pexies. So do it with a spay. Complications. Overall complication rate is 76%. But when you hear things like that, you have to take into account everything from like incision inflammation to death. So it's why it's so large there. Acute renal injury, probably because of vascular compromise, being in shock, maybe bacteremia, but 3 to 8%. Disseminated intravascular coagulopathy, so DIC, 8%. Arrhythmias, 30 to 50%. Splenic thrombosis, 3%. Peritonitis, 5%. Recurrence, the recurrence should be 0, obviously, for GDV. Usually what I tell pet owners is, if there's going to be a recurrence with this, it either is because the patient has sufficient comorbidities that didn't allow it to heal well, diabetes, Cushing's, cancer, whatever, or just by virtue of the fact that the dog is older and they just don't heal that well. But I can't recall ever having a recurrence with this. The adhesion is pretty secure. But you have to warn them about it because it's not 0, it's 0 to 15. And so there is always a possibility of recurrent GDB for whatever reason. If you have a dog that has a motility issue, which I believe a lot of these dogs probably do have, then they could still bloat in the future. They just don't have the volvulus, right? That's the whole point of the surgery. So it's not like these dogs are free of any gastrointestinal disease forever. If they have an inherent motility issue, pet owners ought to be aware. This is going to, if this heals well, this is supposed to fix the emergency part of this, right? It's kind of like doing a laryngeal paralysis surgery. Like you're not fixing like the main problem. You're giving a pretty permanent Band-Aid. Blocked cat, same thing. You unblock them, you're not really fixing the problem, you're giving them relief right now to prevent an emergency later on, and that's why you do a PU surgery, for example. So anyway, recurrence. Arrhythmias. So let's talk about this for a little bit. So ventricular arrhythmias in these dogs are very common, and what do you do as far as treating them? Let me see if I have a slide with this or not. Okay, so how do you decide when to treat for arrhythmias? Typically, there's two different times I'll treat for the arrhythmias. Either the dog is clinical for it, regardless of how many arrhythmias they're having, so they're showing things like dropped pulses, they're lethargic, they've got muscle fatigue, pale gums, you palpate the pulses in the back and they're just kind of thready. Assuming that there's no other reason for this, like anemia, or you haven't caught up with their fluid therapy, if they're clinical for it, even if the cardiac arrhythmias are not that high in terms of what percentage of a strip, let's say a 1-minute strip has VPCs in there, if they're clinical, then I want to treat them. Or if I'm seeing 30% or more of a given 1-minute strip that's VPCs, so 30% of that strip or more is comprised of VPCs, then I'm going to treat them even if they're not clinical for it, kind of obligated to. That's what I've been using as my own rules. And so that's one aspect to this. The second aspect is, well, okay, you treat them, you cut the dog, they do well, you treat the arrhythmias, they're doing well, they go home. Well, how long do you treat them for? How long do you have them on meds for? And I typically have them until the first recheck, so 10 to 14 days post-op, and then I recheck an ECG and see if there's any VPCs there. Now, that's kind of crappy because we all know that VPCs can happen anytime in a 24-hour period, right? And unless you're going to put a Holter monitor on these dogs, we don't really know, if it's in the absence of clinical signs, whether or not these dogs are getting arrhythmias at home and just not clinical for it. And so I'm sort of doing it just sort of to be on the safe side, but I don't have a strong medical argument to make other than it seems to work out well. I see them in 2 weeks. I don't see any arrhythmias at that point. I tell the pet owner, yeah, as of right now, I don't see any arrhythmias. We can stop the medication. We're good to go. And can they have an arrhythmia later on from this? Sure. I don't see it that often, or at least I don't hear about it, but it's just, there's not an exact science that I can think of yet other than having a Holter monitor on these dogs to see whether or not they have VPCs beyond that. We do know from studies that you will miss VPCs if you do spot checks in the hospital, and they do have VPCs afterwards, but for how long? Don't really know any longer term studies for that. The other key point to that is if you are going to cut a GDV in the hospital, and you would first of all, put this on your radar to actually check for this stuff pre-op, intra-op, and post-op, and however you want to do it is fine. Obviously, continuous readings is better than spot checking. So most hospitals, if you don't have the access to continuous, I recommend every 6 hours to do a strip 1 minute or so and see if you can catch a VPC or not. Obviously, if you're not monitoring continuous, but the dog all of a sudden is destabilizing, besides checking the blood pressure and a PCV, you're going to also check an ECG and see if there's VPCs there. Does that make sense? Kind of general guidelines that I've used for this. If you're lucky enough to have an internal medicine doctor, during the daytime, and then just ask them what to do, and let them let them make the call. Otherwise, if you're just a surgeon and you're doing this, then those are my guidelines for it. Because these dogs are older, large breed dogs, they already have multiple other issues going into surgery, and they're recumbent for a certain period of time after surgery. Bronchopneumonia is a concern, and so you want to get these dogs, if they're able to, up and walking to prevent the development of pneumonia. So either get them up and walking every 4 hours or so just to get the airway movement going, or if they are really compromised in their recumbency, then either keep them in sternal recumbency to increase tidal volume, or rotate them the lateral recumbency left and right every 4 hours to try and help prevent atelectasis and then bronchopneumonia. So just something to keep in mind with these dogs, because they are older, they are larger. The incidence and mortality factors, wide range, of course, because it's a complex disease affecting the entire body. So survival is usually pretty good. I would say this is pretty accurate. Obviously, with no surgery, they're not going to make it. This is a surgical disease. How they present to you at the hospital, so comatose, obtundant, lateral recumbency, there's a massive risk of having issues with these dogs, of course. There is a slight increase in mortality if they need a splenectomy. That's not a surprise there. The more compromised the dog is, the worse the prognosis is going to be. Gastric necrosis is absolutely terrible. I don't think I've ever had a dog that I've resected the stomach that's lived. I also haven't done very many because I tend not to see this problem that often, but it's just, the prognosis just sucks with gastric resection. How many folks here had done gastric resections for GDVs? Yeah. Would you say that the outcome, the ones you've done, yeah, they're not good. They don't do well. They don't do well. And you know, if you're going to resect the stomach, you're not looking for margins, right? You're not removing a tumor. You just want to remove the part that's not healthy. So you can literally just hug the portion that's compromised. But these dogs, I don't know. They don't do well. So if I can convince myself that I'm going to leave the stomach alone, I'm going to try to. Whereas the spleen, I'm pretty proactive with the spleen. If I'm questioning it all, I'm removing it. The stomach, I'm trying to make the argument, can I save this stomach? Can I just leave it? I don't really want to resect it. And I don't have the answer. It's just a matter of doing a lot of these and sort of making your own call with them. But substantial risk with gastric necrosis and mortality. Lactate we talked about, can be used as a prognosticator. And there's other biomarkers. Your proceedings have a lot of information on various biomarkers. It gets quite complex. And a lot of it is sort of unrealistic for your day-to-day clinic. But just so you're aware that they're around. Okay, key points. So obviously with GDV, prevention is ideal, of course. So if you can have a prophylactic gastropexy, whether you're doing it laparoscopically or you're doing it with a laparotomy, have at it. It's great, especially if it's female, because you're going to be in the abdomen anyway, but for males too, for the appropriate dog. Talk to the owner about pros and cons of doing that. Definitely acute and peracute disease is more common than chronic, but let's not forget that chronic bloaters do actually exist. I think these dogs ought to get as much of a workup as possible to figure out do they have a primary cause as to what may have led to the GDV. Again, obviously, if you're in the middle of the night in an emergency hospital, you want to get the dog cut. You're not going to you're going to do a workup that is sufficient enough to let the pet owner know, hey, we're ready for surgery, let's go, and there's no glaring reasons why you shouldn't cut the dog. But as far as a more thorough workup involve these dogs, I think there's something to this. I'm just, you know, I always get weary about idiopathic diseases because idiopathic tells me either it truly is idiopathic or we haven't looked hard enough. Oh, towel clamp, that's right. So let's go back to this picture. This will help you guys out, especially if you're just starting to cut these dogs and you don't have a lot of help in surgery. So again, as a surgeon, I get spoiled. So I can have like an intern or resident with me holding stuff or tracting stuff. I can have my technician scrub in if I need to or put gloves on and help me. But let's say you're alone in surgery, your tech is busy monitoring anesthesia, the patient's unstable, you don't have any hands on deck, it's only you. So if you take sharp towel clamps, hopefully you have towel clamps at the hospital, you take sharp towel clamps and you can clamp it to the abdominal wall, not the skin, the muscular part, so like where the linea would be, and you can use that to retract the abdominal wall up towards you. What that'll do is it'll allow you to see the incision that you've made in the abdominal wall, and then this is the semi-tricky part. You want to have your needle holders with the needle and the suture ready, primed, ready to go, and you're going to use the needle to pick up the stomach wall, go through it, go through the abdominal wall, right? Release the needle holders, grab the needle, come out, and now you have your two strands, and you can let go of the abdominal wall, tie. You're ready to start your continuous pattern after you made the first knot. Pull the abdominal wall back up with the towel clamps, simple continuous with one hand, right? And then same thing when you're at the end of the simple continuous pattern, you can go through the stomach, go through the abdominal wall, let go of the abdominal wall, tie, and then you can do the second layer, same thing. So if you can hold that stomach wall up with a towel clamp with your non-dominant hand, and then use your dominant hand to do the closure with one-handed, that helps a lot. That retraction is really good. And that's useful for a lot of abdominal explorers that are large breed dogs, or even like a spay. If you're a doctor who's like terrified of doing large dog spays, and you don't have access to like valve floor retractors, for example, you can use the towel clamp technique to try and help you out. Take some practice, of course, because you are still doing the other portion, the most important portion of the surgery one-handed, but this helps replace an assistant if you don't have the luxury of having somebody in there with you. Yeah. The problem with these surgeries and using valve floor retractors is that when you're opening the abdominal wall that way, but you're trying to attach stomach to abdominal wall, you're fighting the expansion of the abdominal cavity with the bowel flora retractors with what you're trying to do with the pexy. Right? They're opposing forces. So I take the bowel floors out for the gastropexy, and then I'll use the towel clamp technique and suture it together. Otherwise, any other abdominal explorer, ideally you'd have some sort of retraction, whether it's a human retractor or it's a self-retaining retractor like bowel floor. You ought to have something ideally to retract the abdominal wall.
So you don't use any kind of retractors whatsoever when you're doing the actual pexy?
Exactly. Yeah. During the actual pexy, the retractors are out.
So that takes the tension.
Yep. Yeah, and so then you can use the towel clamp method to apply tension to help you with your suturing. But yeah, you don't want that abdominal wall opened up when you're trying to pexy. You're fighting. And if you, let's say you did manage to do that, right? Well, then now you remove the retractor after you're done pexying them, and your incision might be loosened now. You've lost all that tension that you've had. So it's so you remove the retractor and then do the pexy. But the retractor is there for the decompression part, the rotation part, for your abdominal exploratory, for the splenectomy, for the gastric resection. You have the abdomen open for that with retractors. Once you're ready to pexy, remove the retractors and then go ahead and pexy. Liver biopsy. So, as a rule, for me, let's see, where is this? Okay. Number one, if I'm removing the spleen for any reason, it's going to be biopsied. Doesn't matter if I'm removing it because it's clearly ruptured or it doesn't look like it's got blood flow. I'm submitting it for biopsy. The client can decline it. That's fine. That's their prerogative. But you are dealing with the same segment of dogs that also get hemangiosarcoma, and so you do it. And for the one dog you find it, you're gonna be like, oh my God, I'm glad I biopsied the spleen, right? Most of the time it's gonna come back as splenic thrombosis, splenic infarction, extramedullary hematopoiesis, like all this like BS stuff. But once in a while you might hit something, and then you're glad you did it. And it's only because the segment of these dogs fit the same profile as hemangiosarcoma. And you're removing the spleen anyway, so as long as finances aren't an issue, no harm in submitting it. And then liver biopsy. So I'm getting liver biopsy in these dogs regardless of whether I'm removing the spleen or not for the same reason, because they are the same dogs that get hemangiosarcoma. And once in a while I'll hit a dog that has got hemangiosarcoma in the liver, even though the liver looked fine on gross inspection, the part of the lobe that I biopsied looked fine, but I'm still getting a biopsy just in case for staging. Pet owner can decline it, that's fine, but liver biopsy is very easy to do if you're comfortable doing it, and it can catch underlying disease. So I do recommend biopsying the liver, regardless of whether or not you remove the spleen. I would biopsy the liver. Yes?
You give the owner that option before the surgery, the liver biopsy?
Yeah, so the question is, would you give the owner the option preoperatively for a liver biopsy? Yes and no. So if my conversation with the pet, it depends on the pet owner, right? So if they're just diving into all these questions about specifics, I'm doing the liver biopsy and I'll tell them later, and then I can ask them post-op, hey, can I submit it? I'll just collect it and submit it. But if the pet owner is like just listening to you, attentive, then you're going to go through your spiel, and then I'll mention it preoperatively. Say, hey, I want to get a liver biopsy. Here's why. Are you okay with that? It's minimal complication risk for your dog. It costs this much more. I think it's well worth it. You're already spending $5,000 plus on the surgery. Can I submit the liver biopsy? And they'll usually say, sure, yeah, if you think it's okay, if you think it's safe, that's fine, Now, if I have a dog that's severely compromised, it's really unstable on the table, where like, I'm just trying to get through it, then I'm okay bypassing this, as long as the liver doesn't look crazy. But a liver biopsy, if you have like a nice cautery machine and a good part of the liver that you can do this with, you can just zap across, look for bleeding, nothing, and then you move on. It doesn't have to be like a big ordeal to get a liver biopsy. Or if you're more familiar with like using a dermal punch biopsy, you can do that as well, and then just put gel foam in there for the hole, but it doesn't add that much to the surgery as far as surgical time, but it's certainly not worth the patient being under for much longer if they're truly compromised. That's not worth it. Patient comes first. We want to get this dog off the table alive. That's the goal. So, yeah, it depends on the client, but ideally you talk to them preoperatively. And then finally, concurrent surgical procedures. So I'm sure some of you had dogs that have a GDV and they have bladder stones at the same time. They've got a GDV and they have a mammary gland tumor at the same time. It's an intact male and it's a GDV. Like, do you neuter them at 3 in the morning when you're having a gastropexy? And so I'm against doing things like that if you haven't talked to the pet owner about it. So you talk to the pet owner and say, look, your dog just happens to have bladder stones. We found it on the x-rays. That's not an emergency. You didn't come in for that. However, do I have your permission? If your dog is stable under anesthesia, this is going to add maybe 20 or 30 more minutes to the procedure. It's going to cost us much more. It prevents you from doing surgery later on for these bladder stones, if the dog does need surgery for stones, as opposed to medical dissolution. But if I think it's okay and it's safe, do you want me to? And then I just let the owner decide. And if they're like, sure, doc, if you think it's appropriate and safe, go for it. Then I will make a judgment call in surgery, depending on how things are going. Am I still going to do a cystotomy or neuter this dog or remove the mammary gland tumor or whatever, or am I going to leave it alone? Because pet owners will ask. They'll say, hey, by the way, while he's under, can you do a dental? Like literally 3 in the morning, and the dog is dying from GDV. Like, can you just do a dental? No, I can. The dog is not stable, but when we get him through this, then have your regular vet do a dental whenever later, not tonight, right? So they will ask. And it's not wrong to ask, because it is anesthesia, right? They're trying to avoid another anesthetic procedure later on. Financially, this concerns. So I think as long as you talk to the pet owner ahead of time about, it's kind of silly to neuter your dog after he's been intact for 8 years, to neuter him tonight with a GDV. But if I feel like it's in the best interest of your dog, I will do it. If not, I have the ability to abandon that plan. And usually they say, sure, that makes sense. At the same time, if let's say you're in approaching a foreign body, we mentioned this earlier, do you pexy them at the same time as like the gastric foreign body? And I would say, yeah, if it's a stable foreign body and you're comfortable with your surgical skills and this pet owner seems amenable to like do whatever, doc, then say, look, you've got a standard poodle, they have a high risk of GDV, he's 3 years old, he's got a foreign body, we see it on the x-ray. Can I pexy at the same time? He has been pexied before. As long as your dog is doing fine under anesthesia, can I pexy? And usually they'll say, as long as finances aren't a concern, they'll say, sure. Have a conversation with them. So otherwise, things like you're in there for a hemoabdomen because of a ruptured splenic mass and they're not pexied, do you pexy them at the same time? I probably wouldn't, but I will leave it up to the pet owner to give me the permission, bless me with the ability to say yay or nay. It'd be great to pexy a hemoabdomen at the same time, but is it worth having the patient under anesthesia for 20, 30 more minutes while you do the pexy when he already came in hemodynamically unstable? Any questions about anything? Yes?
Just like in a prophylactic gastropexy, like just given anatomic variances, like can you tell us how you map out your approach?
Mm-hmm. Yeah. So the question is, due to the anatomical variations between dogs, can I give you my anatomic approach for where to make the incision? We'll look for like a nice picture, maybe this one. Yeah. Oh, this is a very extreme gastric resection. I mean, that's yeah, it happens, but that's crazy. By the way, real quick before I address your question, the most common area to find gastric necrosis or gastric compromise is up by the cardia, and usually it's not even on the ventral portion of the stomach that's looking at you, it's underneath. So typically if you're looking for gastric, you should be looking for gastric necrosis, I want you to de-rotate the dog's stomach, you're going to lift this portion up towards you and look underneath. And you want to look underneath here, not just on the stomach, but as far close to the esophagus as you can. That's where a lot of the erythema is going to be for these dogs, is on that back side. Just it could be anywhere, but you want to make sure when you do your explore, you're looking underneath too, because you'll miss it there. Okay, so as far as the anatomic variation, so typically you're not going to make the incision over the pyloric region, and certainly this is going to be way too far, especially if you are able to get the stomach from this portion to the abdominal wall, you're probably going to cause a gastric obstruction just by your pexy. You're looking at this area right here. This is where you're looking at. And you want to, if you're going to do it in this area, which is where you ought to do it, you're going to try and do it somewhere in the center because you want to avoid these blood vessels. Although if you do hit a blood vessel, it's fine, it'll stop. As long as the dog has normal, coagulation abilities, it'll stop. But if you stay in the center here, it's pretty avascular. And typically it's going to be somewhere between this area where you see the angle here, right? And then where the pyloric outflow starts, so somewhere around, where this vessel is. So right in this area here, and then so whether you're going closer to this area or this area depends on the dog's anatomy. But the other determining factor here is going to be the abdominal wall. So if the stomach, the gastric pexy is going to be attached to the abdominal wall. So you want to see, okay, I want to make my incision in the stomach here-ish. Does that match with the abdominal wall? So I do a trial run. I take the stomach, I literally have it kiss the abdominal wall. Does that feel pretty good to me? No, let me move it up a bit, down a bit, and see where it fits. And once I kind of have in my head, I mapped out where I want to make my incision, then I make my incisions and go from there. So you just simply take the stomach, make it kiss the abdominal wall, and see if it feels pretty good. One time I had to do a left-sided pexy in a dog, a brachycephalic dog. I was doing a hiatal hernia repair, and I couldn't. It was supposed to be like a Boston Terrier or something, and the belly was just so stupidly shaped. I could not get. I was pexying just because this pet owner was so focused on the gastric dilatation. I said, well, I can try and pexy your dog, although GDV doesn't really happen, and it happens rarely in small breed dogs. And she was insistent on it. I said, oh, yeah, I don't mind, it's fine. And I could not get this side of the stomach to even touch the abdominal wall. And so I did a left-sided pexy. Probably dumb, I don't know, but whatever. Yes.
I'm just looking at the suture pattern you have going on there on the gastric wall there.
This?
Could you just, yeah.
So the question is, what's up with the suture pattern here? I don't know what this is. It looks to me like a subcuticular pattern. So it looks like they're trying to avoid entering the gastric lumen by placing the needle's split thickness between the two layers of the stomach wall. That's what I think they're doing, but it reminds me of a subcuticular pattern. What you're going to do with a gastric resection is the same thing you would do with a gastrotomy, a two-layer closure, right? So yeah, so first an opposing pattern, so usually simple continuous, and then after that, an inverting pattern of your choosing, and that's typically how you're going to repair these. But yeah, to me this looks like a subcuticular pattern, but you would never close a gastric resection or a gastrotomy ideally in just one layer. You're going to do two. So I'm going to assume this person then followed this up with an inverting layer afterwards, I presume. But yeah, it looks like subcuticular to me, but I don't know what that is.
Artist privilege.
Yes, yeah, artist, yeah. Any other questions? Yes?
What are your take-home instructions for feeding and drinking afterwards?
So what are the take-home instructions for feeding and drinking afterwards? So ideally, theoretically, I don't have to change anything because I fixed their GDV and they're no longer at risk for volvulus again, assuming they heal up. However, what I tend to do for pet owners who are willing to do this is I will give them the same instructions I do for laryngeal paralysis surgery. Elevate the food bowl, minimize dust inhalation from kibble by either adding water to the food or changing over to a canned food diet. And for dogs that really wolf down their food, maybe either slow it down using those bowls like a maze where they have to eat around the maze, or put large toys in their bowl so they eat around the toy so it slows down their feeding, or hand feed them if you have the time, meatballs. And then activity. So I don't want them now, they're going to increase the number of meals they have. Let's say this dog usually eats once a day. Let's go with 2. Let's split it up and do 2 meals a day because we know that lower meal counts are a risk factor. And also, no more hiking, running, jumping right after you just ate. Give it an hour or 2, and then you can play with your dog. No matter how excited the dog is to see you after work and you're about to feed the dog, calm things down, let them eat, and chill out for an hour or 2. So I don't push it too much.
No, like more immediate post-op. Like
Oh.
you have them do like small meals like multiple times a day. Do you limit how much water they drink at any one time while you're waiting for the adhesion to form?
Oh yeah, so the question was an immediate post-op. Yeah, so once they are able neurologically to ingest food, then I'm going to be feeding them small amounts frequently, and usually I have the nurses make meatballs and feed them that way. And my goal with that is to prevent vomiting post-op, which then of course risks aspiration pneumonia, and so that's why I'll feed them slow that way. And usually a bland diet, like low residue or Hill's ID, that kind of thing, whatever bland diet you have in the hospital. But yeah, as soon as they want to eat, they can eat, because theoretically, even with a gastrotomy, but usually you're not going to be entering the stomach of these dogs. There's no defect in the stomach, and so they can eat right away. This your pexy site is not entering the lumen, and theoretically you haven't entered the lumen for any reason, so they can eat as soon as they want to. Now, if you think there's pancreatitis there, and they still have GI signs after surgery because of pancreatitis, then you do whatever your regimen for pancreatitis is. But routine GDV, they can eat right away.
I think I just always get paranoid that it's gonna rip off the body wall if they have too much food or water in their stomach at any given time.
I have not seen it, and yeah, and these dogs are usually sedentary older dogs anyway, and they're in the hospital setting, and they're just recovering from being in shock and whatever else. I don't see them like wolfing down that much food, but again, usually I'm just having them hand feed anyway, small amounts to try and prevent things from coming back up. But no, not that. No, not that. It would take a lot. I mean, you'd have to really fill that stomach up to do that. Yeah. I don't think it's much of a concern. Yes.
What's the thought about any pro-motility drugs or anything for long-term post-op?
So the question is pro-motility drugs for long-term post-op, and I'll even talk about in the short term as well. So I'm a bit old school when it comes to like using Cerenia as part of your pre-med protocol, so I'm out of the loop with that. So Cerenia does help with anti-nausea, obviously, it's not a prokinetic. So I'm still a big fan of Reglan. I'll use metoclopramide for GI cases, and sometimes they'll get an injection at the time of induction of metoclopramide. The idea here is to get the intestinal tract moving so that we don't have regurgitation intra-op and immediately post-op. And then if I'm really worried about motility in these dogs, I'll have them on a metoclopramide CRI after surgery. It tends to be cheaper with a CRI than every 8 hours giving a bolus, and it seems to be, I think anecdotally, I think more efficacious if they have a concentrated infusion of Reglan as opposed to TID injections. But anyway, so that's a case-by-case basis whether they're on Reglan post-op or not. For long-term, it depends on their history. That's why I like to investigate their history as much as possible, because if this dog has had chronic fluctuating GI signs forever before this GDV occurred, then I'm usually going to put them on something post-op to go home with, maybe Pepcid or omeprazole, maybe one of those two drugs plus oral Reglan, and seeing if the owners notice a difference. Now, do they notice a difference because the dog is now Pepcid, or they notice a difference now because they're on meds? I don't know. But it's worth it, I think, for those dogs to have a chronic history of this. Lifelong depends on the pet owner, and if they're like, wow, doc, this Reglan does wonders for my dog. I have had no GI issues for a month now. Can I continue it further? And I don't know what the long-term safety is for that drug, but my answer is like, yeah, sure. If you think it helps, let's do it. In fact, why don't we play around with the frequency? Maybe you're doing TID right now, correct? Okay, let's do BID for like a month and see what happens. And if that works for you, let's go SID for a month, see what happens. Minimum amount of drugs needed to solve the problem. But I'm for all that stuff, especially in pet owners that are very clear that their dogs have chronic fluctuating GI signs forever, and I have no problem putting them on those drugs post-op. Yeah. Yes.
If we don't have overnight care, and the owners can't afford referral to an overnight facility post-op, are you opposed to doing like a lidocaine CRI?
So the question is, if you don't have 24-hour care and there's no access to like an overnight facility post-op, am I opposed to lidocaine CRIs? Maybe, it depends. So if you're using the lidocaine as a method to tackle really bad ventricular premature contractions, VPCs, then you're kind of obligated to, because that'll kill the dog. So you do what you can with the lidocaine, and ideally procainamide as well, but lidocaine will work faster, of course, while you're waiting for procainamide to increase in the body. So in that case, it's worth whatever risks you have. The risks with lidocaine CRIs are neuromuscular weakness, and these are already old dogs that are debilitated, and nausea because of GI motility changes from lidocaine. Now, if you're using lidocaine for pain relief and not for arrhythmias, then I would say it's probably overkill. I would either go with intermittent opioid injections, or if the dog is able to take oral meds, gabapentin and tramadol. I'm not going to use NSAIDs in these dogs. Between the acute renal injury that they're at risk for and all the other vascular compromise, plus the stomach did undergo major trauma, even though you didn't enter the stomach. I'm not using NSAIDs in these dogs. I know surgeons that do use NSAIDs in these dogs, so it's either way. But yeah, so it depends on why you're using the lidocaine. And then the other thing is, does your question allude to a pet owner going home with a dog with IV access? Or is this like, we're gonna stop treatment once the dog goes home and then they'll come back tomorrow morning for readmitting?
This is, I cut the dog at midnight and I go home till I come back at 6 a.m. and no one's looking at the dog.
But the dog is in a hospital, but no one's physically there. Oh, okay, yeah. I think you have to weigh the pros and cons of it, but in the immediate post-operative period, if you're using lidocaine for heart arrhythmias, it's probably worth the risk of not having maintenance, not having monitoring there. If you're using for post-operative pain, I would forego it and give them an injection of hydromorphone or buprenorphine beforehand, and then when you come back in the office, do it again. Less than ideal, but you have an alive dog. Who cares,
Yeah,
right?
That's an ideal.
Right, absolutely. Look, with veg triage, we work with areas of the world that are very, very rural, and we have pet owners. I'll tell you this story real quick. Alaska, this owner called us for a Great Dane that had on video, this is telehealth, on video had a GDV. Nothing else it could be, right? A 6-year-old Great Dane with non-protective retching and abdominal distension. And there is no emergency care. The next time they can get emergency care will be either they have to get a flight or a ferry ride 2 days later, so it's like a Friday night, or the next time a hospital is open again and see them is Saturday the following day at like noon. So and this is like 9 o'clock at night on a Friday. We had these owners rotating their dog in whatever direction until it decompressed on its own, which it would do in their living room. It would vomit up all this stuff, all this gas would come out, its stomach would be nice and flat, and then like an hour later it would rotate again. They would rotate the dog, it would decompress. That dog stayed alive and got to surgery the next day at noon. So overnight, so no overnight care, but they're in the hospital, fantastic, I'll take it. Because this stuff is really extreme, not ideal, but these are cases that we deal with because there's nothing around. Block cats, same thing. How do you manage a block cat for 2.5 days before it can get on a plane and go to a vet hospital? Those are things we contend with. So yeah, I'm on board for whatever you can do to save the animal's life, best case scenario. Any other questions? Yes?
For your post-op antiarrhythmics, I'm presuming you have procainamide up there, injectable. Are you using procainamide PO2?
Yeah, so the question is procainamide. What are you doing for arrhythmias for post-op? So lidocaine in the acute period where I'm really worried I need something right now, it's going to be usually a lidocaine bolus followed by a CRI, and then you titrate that CRI depending on the response. If you're not happy with the bolus, like the VPCs are really bad and you're not happy with the bolus, you can repeat one more bolus, but then start the CRI. And ideally, when you're bolusing these dogs and have them on a CRI, ideally you're also having on a continuous ECG monitoring. Procainamide starts at the same time. I'm not as familiar with IV procainamide. If I had an internist there and they told me to, I would do it. Otherwise, the way I was trained was they start intramuscular procainamide at that time, and basically they stay on IM procainamide within QID until they're able to take oral procainamide, and then they're on oral. And then they go home for 10 to 14 days with oral procainamide. As you're giving them the injectable procainamide and they're on the lidocaine CRI, hopefully you can start weaning them off lidocaine because it'll affect their ability to eat and get around in the hospital. And so hopefully the VPCs are getting better. You can start lowering the CRI. You don't even need to titrate them off of lidocaine. You can just stop it cold turkey. But most of us feel comfortable sort of lowering and seeing where things go before stopping it completely. And then procainamide is IM until they can take orals. And then for 10 or 14 days for the incision check, do a spot check, ECG, no VPCs, talk to the owner, look, right now there's no VPCs. You haven't described any symptoms at home of VPCs, let's stop procainamide and we can always restart it if something wacky happens in the future. Yeah. But I will defer to folks who are much more comfortable with cardiac drugs than myself. This is the way that we would do it, and I hate that answer of this is how I've always done it, right? So people can use procainamide IV, I've only done it when an internist told me it's okay to do it. Otherwise, I'm scared. Any other questions? Thank you, everybody. Appreciate all the questions and your attendance. Thank you. Thank you.